So I wanted to apologize right at the start because needless to say, there's going to be lots of strands of discussion, lots of thinking that we are going to have to park and pick up again tomorrow and Tuesday, because I know that with Jaime, whom we're just about to talk to, we've got 30 minutes for him to tell his story and have some Q&A, and then later we've got 30 minutes with Siri as well, and each of them, just as yesterday with our speakers and interviewees yesterday, each of them could have half a day to explore what they're talking about. So please bear with us. We're going to be quite compressed, but boy, is it worth hearing their stories. Jaime is someone who has, as it were, lived the right to health. It's something, and we can ask him in a moment how far it was conceptualized in terms of the right to health, but it was absolutely the embodiment and the execution of the right to health. And this is around MDR-TB, multi-drug resistant tuberculosis, and tackling this in a way that was thought impossible. A few years ago, famously, there was a political catchphrase that was coined, which was, "Yes, we can." Now, I think that very much expresses what Jaime was doing with colleagues, and he'll explain the story in detail. But first, we're going to have a slide, I think, of somebody called Paulina. And first of all, I'm going to ask Jaime to tell us a little bit about the background of this.
Okay, thank you, John. Paulina, it's a woman who was living in Carballo in the northern corner of Lima. And back in '96, she went to the emergency room, and I was with her at that time. And when we were trying to get the medical care for her, the doctor said, what are you doing here? I already told you that there is nothing we can do for you. I mean, we were trying to treat you for more than 2 years, but now, I mean, there is no cure for you. So I'm sorry, but there is nothing we can do. And this picture is 1 hour after we left the emergency room. And she asked me, do you mind taking a picture? Because Percy, the son, may not be able to remind me years later because I may not be here. And that was really hard. And certainly it was in the middle of a struggle where in the northern corner of Lima, we were trying to set up ways to treat multi-drug resistant tuberculosis in a very poor setting. But when we were looking for international advice, the international scientific community was telling us that's not possible. We don't have enough resources to treat tuberculosis around the world, and we are not going to spend the money treating MDR-TB patients. Do you have an idea how much it costs treating MDR-TB patients in the world? $250,000 US is how much US is spent in each patient in New York. And you want to try to cure MDR-TB patient in Peru? That's crazy. Not possible. No way. So that was it.
Seems to me, Jaime, what you're describing here is actually a mental map that you were facing.
Yes.
Could you tell us a little bit more about this mental map? You've told us about the cost.
Yes. And
what else was there that was saying we can't do this?
Well, when we are trying to work under, programs, guidelines from developing countries, and I will say everywhere, you are trying to follow guidelines, and you have guidelines everywhere that try to teach you the best way to approach a problem. And those days, tuberculosis, it was something that the doctors around the world were trying to implement one strategy, DOT strategy. So one regimen, short course treatment, 6 months, and try to implement it in a way that you supervise the treatment and be sure that the patient take the meds, and the patient bring the sputum sample so you can follow the course of the disease and declare cure after the end of the treatment. And not all the countries around the world were eager to follow that strategy. So it's like we were trying to work in one of the best example of how the DOS strategy was implemented in the world. So Peru was awarded as one of the best national TV programs. And Paulina was there saying, hey, I'm here. She was not part of the, she was somehow the outlier. So the pattern was, was trying to, the statistic was showing that DOTS program, the implementation was going well around the world. It was going excellent, certainly in Peru, but there were some cases that were not really, following the pattern. And, but not because there is something that is not following what you are trying to do. It's a situation where you can say nothing can be done.
So just to check I got this right, you're in a situation where clearly the program is failing in many cases, but there is a degree of sort of self-congratulation that this is as good a program as it can get.
Yes, because we were told this is the best you can do with the money that you have. So what you are doing is good. I mean, and because it's very good, here is the price.
Okay.
So it's like the best national TV program. I'm sorry, MDR TV cases, they are so few. We just need to keep doing what we are doing good so far.
Okay, so Jaime, can you tell us how you approached this in terms of making change? Because you did not believe that this was the best possible program. So where did the inspiration for change come from, and what was the sort of change that you and colleagues pioneered?
I think that when we face moments like that with Paulina and Percy, that was something that certainly we cannot take it as, this is the end. There is no hope. And when I was working as a doctor there during that time, I didn't have much experience about how to treat MDR-TV, and the information available was really short. And the successful story were coming mainly from US or Europe, but nothing coming from developing countries or something that you can rely on a colleague near you who can guide you what will be the best way to do. And what I felt very lucky in my life is trying receive the opportunity to meet people that were also very well committed and passionate about what they were doing, and in ways to show that pragmatic solidarity is not just a statement, it's something that you can apply in your life, in the work that you are doing. I was very fortunate to work with the colleagues at Partners in Health, and they were a group of doctors that and volunteers who were very well committed to make the change. And during those days, what I was told is the mission. We want to make a preferential option for the poor. But what it means in terms of Paulina, well, it means that we have to do whatever it takes. Okay, so then I have it clear how far I can go. And one of the most difficult issues that we have to face was the cost of the medicine. How we get the drugs that, it's really expensive. And there was a mechanism, the Green Light Committee mechanism, that allowed the project to reduce the cost of the treatment. So at the beginning, we were spending $30 per injectable per day during 9 months. And suddenly, after this mechanism, we got the same injectable, and we were paying only 99 cents. So how can you reduce $30 to 99 cents? That shows you that, the drugs can certainly be, the prices are not really showing, what was the real cost of the drug. So it gives you an opportunity to try to frame your work in a different way where you can design a regimen that could be really a good one and save more life. Not just Paulina, more patients.
Could you explain a bit more how the cost was driven down so radically?
Well, it was a good example of what partnerships can do. So when we were getting together in meetings like this, the international community was following year by year how Paulina and the first 75 patients were doing. And when we were able to show that by month 6, 80% of the patients were smear and culture negative. That shows promising. And when you show that in your pilot study that you are getting very good outcomes, that's how others, partners, decided to get involved, become very interested. So CDC, WHO, Pan American Health Organization, other universities, Partners in Health, Harvard, and others come as a group and discuss what mechanisms we can build in a way that we help to reduce the cost of the drugs. But it won't be just reducing the cost of the drugs, because there was also the need for technical assistance. What if we, in the process of trying to reduce the cost of the drug, we start giving transferring the experience of the clinical management of these patients from US or Europe to developing countries, and work more like as a team. And that way, the pharmaceutical become more interested, because they say, okay, so if it is going to be in a setting where my drug is going to be very well used, and we are not going to get again in a drug resistant, creating more resistance, then I'm interested. Let's try to work together. And they started with a very concessional price, and because there were a large group of interest trying to implement also this treatment in other parts of the world. It's like instead of having 10 patients in one developing country, suddenly you have 10,000 and probably 100,000 patients. That certainly is more appealing to pharmaceuticals as well.
Thank you, and I think this may well be something we can take up later in the morning when we look at essential medicines and the role of pharmaceutical companies.
Yeah.
But it's not just about getting the drugs into place at an affordable cost, is it?
No.
There's also issues around compliance, and something you come up against again and again is, no, we can't, because there won't be compliance. Because particularly poor people will not be able to manage their own treatments, and we don't have the wherewithal to ensure compliance. That's another sort of part of the mental map you were dealing with, isn't it? And how did you respond to that?
Yeah, they were saying that, because this is going to be in poor settings, and they probably will be illiterate patients, so they will not really follow medical recommendations. But it was really difficult, because the doctors in the area, they didn't want to spend extra time trying to explain to the patient what was the treatment about. So they were so afraid of getting infected that they preferred to spend less than 3 minutes and say, okay, that's it, no more. But we were very fortunate to start working from the beginning with a group of volunteers from the community. When we get together for the first time, we ask them, this is the situation. What would you like to do? And they said, well, if this is happening in our community, and we are going to be growing here, and we will be having our families living in this community, we have to do something now, not later. And let us know what we can do. And we start training them in a way that they understand all the process, how the mycobacterium was actually creating more resistance over time, what will be the regimen that the patient will receiving, what will be the most common side effects, and what were so far the strategies that around the world somebody was using to deal with the side effects that are clearly associated with the treatment. But more importantly, we told them, we have to be sure that the patient take the meds every day. But in the process of seeing the patient taking the meds every day, we need to know what else is going on at home. So when you go to the house of the patient, we need to know are they having enough food? Is the house big enough? Is the house very well illuminated? Is the house very well ventilated? Are they having a job? Is somebody taking care of the kids? So it was more than just how are you doing? And it was more about, it was not just about fever. It was not about coughing. It was trying to learn more about how was really life with those patients. And when they came back to the clinic every month to see the doctor, so then you have a doctor that pay more attention on what was happening with the family. Yes, they are taking the drugs, but they don't have foods, and I think that they are having a very hard time trying to feed the kids. So after that, you have to start working on trying to develop a new strategy. Okay, now we reduce the cost of the drugs, but that's not good enough. What else we need to do? So we have to start looking for ways to bring food, not just for the patient, for the families. We have to start looking for ways to get additional support to build a new bedroom, or to improve the house in a way that we have a more well-ventilated house and more well-illuminated house, because we knew that doing that, we will be taking care of the infection control that you must have in a house. And you will be, you will be creating a hard time for the mycobacterium to survive, with sun and very well-ventilated environment. So those lessons, I think that were coming from a group of very well-committed members of the community, and I'm very, I'm very proud of being a good learner from that group, because I think that after that experience, knowing that how well it worked, teaching community members the full package of an intervention, they were also eager to try to apply the same model to another group of patients that were told that they were also difficult to treat. The HIV patients, and in Peru, the mothers with HIV and the children with HIV in my country were supported as well by this group of community care workers.
Thank you very much. This seems to me a great example of how to make change, to look to the future. You need dialogue, which leads into co-creation, and that it's a mutual process of learning. It's not simply top-down, which so often is the view of the need to distribute the right to health. Another point which is so important, of course, which has already been cropping up in our concern about definitions, is that this is not about simply the right to see a doctor and get treatment. The right to health is something much broader. You have to see it in a broader context. And you've alluded to the discussions with the community. And of course, this hasn't simply been, if you could just elaborate a bit more, it's not just doctors talking to the community, is it? Who else do you need to bring in? How does it all work?
I started telling the story saying that the community volunteers were the first one who jumped right away into that discussion. And then it was a time for the doctor to take care of the clinical aspect. But that was just the beginning, because then all other health professionals in the long run find a way to do something about it. It's like the nurses find that they were the best one to scale up this strategy around the world, not the doctor, the nurses, because they receive a training, so they can easily set up programs. They have very good skills in terms of scaling up successful program. But in the psychiatrists and psychologists, there were also a group of professionals who received a very important task in terms of dealing with patients that were afraid of the side effects and wants to abandon the treatment right away. So, but when they received the support from psychiatrists through therapy groups, that was really helpful to them to adhere to the treatment, using the testimony of a patient that already go that way. So somebody was cured or in the process of being cured was part of the therapy groups, teaching the others that they were doing the right thing. But what I like most in this journey is that it gives to everybody the opportunity to do something. It's like I found people say, well, I'm not a doctor, but I'm very moved for what she's going through. What can I do? And some of them were just not just they were businessmen who were wondering if an extra cash will help. Yes, I said, in this process, we are having patients that are receiving treatment for 2 years. They are going every day to receive drugs in the morning, drugs at night, and but nothing in between because they have to start dealing with side effects, and they are at home wondering, what's going to be my life after I get cured. But there we have a very good opportunity to start teaching them something. Why don't you help them? I know that you have colleagues who teach how to run small business enterprises. What if we set up a group that you get a group of professionals who can start teaching a group of patients? I promise that they are already cured, so don't get afraid of getting infected. But so we ran that experiment, and the patients started doing small businesses, so they can start earning their own money. They certainly get very confident in what they were doing. And show a good example for the new patient who start receiving treatment. So, that's just one quick example of, what you can do even though you may not be closely involved in health.
That's very interesting, of course, an example of cross-sectoral teamwork and the development of new and innovative teams, and also people leaving, as it were, their professional comfort zones and doing things that they wouldn't have anticipated that they could previously have done, but leading to such extraordinary payoffs. Now, there's so much more to Jaime's story, but I think I want to ask one last question and then allow for comments and questions from the floor. And the last question is, what happened to Paulina?
Well, certainly I will need more time to explain what happened with her life, because it's an amazing story that she has to tell. But I certainly ask her permission to share her story everywhere I have to go, and she said yes, certainly you can share that story, and the reason is because you saw me talking to you about the story of Paulina and Percy. Now you are seeing Percy and Paulina. How big is Percy now? And they are doing just fine. And it's good to see how Paulina is keep fighting. And last April I had the opportunity to go down there, and he was with one of the doctors that was supporting her from the beginning, with Dr. Jim Kim. He was there the day before he was elected as the new president of the World Bank, and she wants to see him because she wants to say not just thank you. She wants to tell him, doctor, what I'm doing now is I'm studying nursing school, and I'm very close to finish, and I want you to know that that's because of your help. So,
thank you very much indeed, Jaime. It's interesting that Jim Kim, now president of the World Bank, was one of Jaime's early partners, 3 partners in health in this work. Someone else who does not accept contemporary mental maps as fixed part of the geography. An intriguing thought, I think.